Welcome to this fourth video of the course Health Technology Assessments, which will focus on outcomes. In the earlier videos you saw a bit about the introduction and what HTA is and the costing, and now we're going to focus on the other part next to costing. Another important part of HTA is the outcomes. You saw this slide before. So basically, this is the total of what an economic evaluation is, and we're now focusing on the outcomes next to the difference in costs, which we mostly express in societal costs. And if we look at the outcomes, what's important is that we overall focus on quality of life. So the QALY is a very important concept in which we differ from normal effectiveness studies, is that we're always looking at the QALY in economic evaluations. If we talk about clinical outcomes and health effects in economic evaluations, there are basically two types of health effects which we use. One is the clinical outcomes, and these are the outcomes which are commonly used in trials. So they're already collected in trials or observational studies, and they are a surrogate outcome. And a clinical outcome, for instance, a blood pressure, is a kind of a clinical outcome which is used in the field of heart diseases. It could also be life years gains, but that means that we only will look then at life years gains and not at the quality of the life years gains. So one part of the outcomes is that we look at clinical outcomes. The other part is that we look at quality of life. Well, we're very much interested in quality of life in HTA and economic evaluations because we value patient-reported outcomes. We really value how the patients, him or herself, look at the outcomes. And we do that by not focusing on one aspect of health, but we focus on a number of aspects. So we look at quality of life from a multidimensional concept. So we look at physical health, mental health, social well-being, and also sometimes other aspects. I will come back to that later. And what you will see is, of course, that in the clinical field, we more and more focus on health-related quality of life. But in economic evaluation is a kind of standard that we also include quality of life in our measures. Why is health-related quality of life so important? One is that it's a multidimensional concept. So we take into account a number of concepts. We look at the social interaction, the living environment, education and work, mental health, being, physical well-being, and other aspects. And why that is important? Because it could be, if you only look at one clinical outcome, people might improve, but in the other domains of health, which you saw here, then you're not improving. So it's important because you want to capture the whole well-being, the whole quality of life of a patient. This is, of course, attached to the growing interest which people have in patient-centered outcomes. And it's also increasingly done in health research and clinical research. And what quality of life measures and health-related quality of life measures want to do is that they aim to better understand the patient's perspective on a healthcare problem. Next to the clinical perspective from the clinicians and the healthcare professionals, it's also important to know what the patient thinks about their current health state. And what we then also often do is not always capture the aspects which are in the treatment, but also aspects beyond that, like can you participate in your daily living, for instance. And if you look at health-related quality of life and economic evaluation, it's nowadays an established part of economic evaluation, and that means that we, in general, always will include health-related quality of life when we do an economic evaluation or a health technology assessment study. Now, there are several ways of looking at the outcomes, and I will discuss two ways. One is that you have to realize that there are basically two types of outcomes. We have generic outcomes, and generic means that the instrument captures all aspects of health. A generic instrument has a lot of advantages. One of the advantages is that these are generic instruments, so they can be used in every disease and every intervention. And that makes it feasible to compare outcomes between diseases. Because you can use it in any disease and any intervention, it's also possible to compare between the diseases. The other one is that it's sensitive to multiple aspects of the treatment. So it doesn't only focus, for instance, on blood pressure, but it looks at the overall well-being, quality of life of a patient and incorporates all the aspects. And it's standardly used in economic evaluations. Of course, with the advantages, there are also some disadvantages. And the major disadvantage of a generic outcome is that it's less sensitive to small changes. I suppose that my blood pressure would increase 1 or 2 points. You could find that in a blood pressure measure. But of course, the question whether a patient would sense that is negative, so they're insensitive to small changes. So one group is the generic outcomes, which includes all kinds of dimensions used in economic evaluation. And on the other part, we have the disease-specific health-related quality of life, like, for instance, the Kansas City cardiomyopathy questionnaire or the health-related quality of life questionnaire. And these are clinically more sensitive. So from a clinician's point of view, they're very well developed. And they're more responsive compared to generic instruments. So the advantages of the disease-specific measures is that they are mostly developed from a clinical perspective, and as a result of that, they're also more responsive to small changes. But they are disease-specific, and that also has a drawback, and that means that you cannot allow to compare across conditions. So you cannot compare, for instance, interventions in the field of heart disease with interventions in the field of cancer, with interventions in the field of depression, for instance. And for a policymaker, for instance, at the Ministry of Health, that can be of major importance. And it's also limited if you, of course, look at disease-specific intervention to a certain population or a certain intervention, because that's basically in the term, it's focusing on one disease. So you could classify the outcomes in generic outcomes and disease-specific outcomes, where in overall, if we look, for instance, at the QALY, we will use generic outcomes. And that brings us a bit to the other classification. Before, you saw that there are several main types of an economic evaluation. Another way to classify the type of outcomes is to look at the different types of economic evaluations. You saw before that we distinguish a number of types of economic evaluation: the cost-benefit analysis, the cost-effectiveness analysis, and the cost-utility analysis. And they differ not in the way which we identify, measure, and value costs, but they differ in the way in which we look at outcomes. In a cost-benefit analysis, outcomes are expressed in monetary terms. In a clinical cost-effectiveness analysis, outcomes are expressed in clinical outcomes or health outcomes. And in general, we will use health profiles or quality of life instruments, but maybe also clinical measures as an outcomes. In a cost-utility analysis, which is the preferred type of analysis within an economic evaluation, we express the outcomes in quality of life, QALYs or utilities. So mainly the difference in outcomes defines which type of economic evaluation you're doing. If you're looking at utilities or QALYs, it's a cost-utility analysis. If you look at clinical or health outcomes, it's a cost-effectiveness analysis. And if you value the outcomes in monetary terms, it's a cost-benefit analysis. What you overall will see that most economic evaluations do a combination of a cost-effectiveness analysis where we combine clinical or health outcomes in combination with a cost utility measure where we look at utilities and QALYs. And now we dive a bit more into QALYs. What is a QALY? QALY stands for Quality Adjusted Life Year. And what does that exactly mean? Well, QALY is a number for your health state, which goes from 0, which is the worst health state or death, to 1, which is the best possible health state or full health. A QALY, a quality adjusted life year, if that's 1, then you have 1 year in perfect health. And what is unique in this measure is that we combine the quality of life, how you feel about your health state, with the length of life, if you survive. And the basic formula to calculate a QALY is that we look at life years gained, the survival, and we multiply that by utility. And the utility is, as we mentioned, the health state in a number varying from 0 to 1. This is a visualization of how we use the QALY. What we see here at the bottom is times in years. What we here see is the quality of life valuation, so the utilities. So if a person dies at the years of 60, you could say, well, somebody starts in full health, quite healthy, and then it goes down and up and down again. And then you can calculate this area under the curve, and that would be the QALYs without an intervention. Well, suppose that we have an intervention, and this is a very good intervention because people live longer, like 30 years or more longer, and they also have a higher utility, a higher value to their quality of life. And then the blue zone would be the QALYs gained based on the intervention, and that's done by multiplying the survival by the quality of life valuation or the utilities. An example in number, suppose an intervention leads to 25 years of life gains and the patient goes from a utility of 0.7 to a utility of 0.79. So it goes on average from a 7 to an 8. Then you could calculate the QALYs gains by looking at the 25 years, multiplying that by the difference between the new utilities minus the old utilities, and then you would see that this intervention would gain 2 years and 25 QALYs. And remember, 1 QALY is 1 year in full health. So if we look at the measurements, it's important to distinguish the different types of measurement instruments. What we would like to have in the long run is preference-based instruments. But I first will explain the non-preference-based instruments. A lot of health profiles are generic health profiles which measure quality of life. For instance, the EuroQoL. They give a kind of overview of how a person feels in different aspects of quality of life. We saw before that next to the generic instruments, we also have the disease-specific instruments. And how we get these instruments is that patients fill in the questionnaires. And if we look at the EuroQoL, for instance, researchers construct a health profile, a kind of description how people are feeling overall if you look at different dimensions of quality of life. In a preference-based instrument, we translate this story, this profile which comes out of the questionnaires into a number, and for that we need a valuation. We need a way to value the health on a scale. There are different techniques to do that, the standard gamble, the rating scale, and the time trade-off, but I'm not going into detail into that. And I will just explain by one example how the difference between a preference-based method and a non-preference-based method is in practice. And we do that by looking at the EuroQol. Well, this is the EuroQol. And this is the instrument which is completed by the patient, him or herself. And what you see here is that the EuroQol has 5 levels: mobility, self-care, usual activities, pain and discomfort, and anxiety and depression. So there are 5 health dimensions which cover the overall health of a patient. And the patients can give an answer to these 5 levels of health by giving 5 levels of answers. And they vary between I have no problems with walking around, for instance, with mobility. I have slight problems with walking around, moderate problems, severe problems, and I'm unable. And in each health dimensions, there are 5 levels of answering. And what the patient does is that he gets the question, this is a description of the health state, and could you please tick what best describes your health state today? And in this case, the patient said, I have no problems in walking around, I have slight problems with washing and dressing myself, I have no problems with usual activities, I have no pain and discomfort, and I'm slightly anxious and depressed. Well, as we saw in the earlier slides, we can make a health profile of this, and the health profile in this case would be 1, 2, 1, 1, 2. That's the health profile. That's a description of how a person is feeling on a certain day. But we want to have that health in a number. And how we do that is that attached to the EuroQol is also a rating scale, a visual analog scale. And that's also completed by the patient, and it says to help people, show them how bad an health state is, we draw a scale, like a thermometer, on which you can imagine that the best health state is marked as 100 and the worst health state as 0. And can you indicate how bad or how good your health is today by drawing a line? Well, in this case, you see that this person said my own health state is 0.69. So if we look at this as a utility, it would be 0.7. So this is the preference-based part. And the first part where we had the profile is the non-preference-based part. Well, if we continue with that, how can we use that in research? What we have is for a number of instruments like the EuroQol, but also the SF36, we have tariffs. So we know a bit if a person has a certain health profile, which kind of utility people will choose. So we have a kind of formulas. If we know that the person has a certain health profile, this kind of utility belongs to that. Remember, we had the patients who scored 1, 2, 1, 1, 2. And based on the population values, we could see that the utility attached to that is 0.723. So people, respondents in a research would fill in the questionnaire. By that we get health profile. We have scores from the general population, so we have population values. And by that, we can attach utilities to each health profile. And we use these population values to get the utility obtained from the health profile from the patients. Like with costing, we have to discount if the time frame is longer than 1 year. And the discount rates in the Netherlands is 1.5% according to the Dutch guidelines, so it differs from the costing discount rate. The costing discount rate is 4%, and the discount rate for effects is 1.5%. So in practice, people fill in a questionnaire, you get a health profile from the patient, and then you get, based on the valuation set, a utility score. What you will see that in the guidelines in most countries, also in the Netherlands, the Euroqol is the preferred instrument. So a lot of guidelines throughout Europe and throughout the world will say, and also in the Netherlands say, that the EQ5D5L, so the Euroqol 5-level version, is the preferred utility instrument. One of the problems which you saw with the Euroqol is that it's quite short, and that's an advantage, and only has 5 levels. But it's very limited in the questions which you can ask. For some populations, you could also use the SF36, because it has more items and it has more dimensions. So for some populations, it's better to use the SF36. And again, you can have utility scores going from 0 to 100, and you can have an overall profile for that. You can also have the psychological part next to the physical part scores for that. And for the Netherlands, like for the Euroqol, there are validated translations and data from the Dutch population in order to compare that. So it's also possible to obtain the QALYs in the Netherlands using the SF36 as an instrument, but preferred it is to use the Euroqol as an instrument. So the overview. What we talked about in this lecture is that we are looking at the outcomes and economic evaluation. What we prefer if we look at economic evaluations is that you look at health-related quality of life. And we do that because we want to include a multidimensional concept. We want to include all the aspects of health when measuring health. We want to do that by using a patient-reported outcome measures. And what you will see that in economic evaluation in HTA, this is standard, but overall it's increasingly used. We looked at the differences in instruments, the generic instruments which you can use in all diseases and all interventions, and disease-specific measures. In economic evaluations, HTA, we prefer the generic instruments, and we also prefer the preference-based instruments, so the instruments in which you can translate the health profile in a number, in a utility, which goes from 1, which is full health, to 0, which is death. So we prefer the preference-based instruments. And by having the preference-based instruments, having the numbers, we can calculate quality-adjusted life years by using the tariffs which you have from the population. And a QALY is a combination of survival and how people feel in quality of life. And that's, for us, the optimal measure to use in an economic evaluation or an HTA study. Well, I hope this was informative. These are the references which we used mainly for the presentation. And thank you very much for listening. Thank you.